Hello to all. I am Varun Kalia, PhD scholar, lovely professional, University, Punjab. My today's topic is effect of myofascial trigger point dry needling in patients with adhesive capsulitis. First of all, about adhesive capsulitis. It is a condition which is characterized by progressive restriction in passive and active range of motions of glenohumeral joint along with pain that leads to substantial disability for many patients. This cause of adhesive capsulitis is poorly understood. Incidence: females are more prone for adhesive capsulitis than the males. In non-diabetic population, 2 to 5% population is affected, but diabetic population is 20% more affected than the non-diabetic population. Next is the pathology. Most of the authors believe that pathology lies within the joint capsule. Inflammation and fibrosis of joint capsule and coracohumeral ligament is the main cause of adhesive capsulitis. Hand G.C. et al. In 2007 said that pathology of adhesive capsulitis is remain unclear. After that, in 2010, Page P. et al. Said that restriction in adhesive capsulitis is not just because of capsular and ligamentous tightness, but also facial restriction, muscular tightness, and trigger points are responsible for the development of adhesive capsulitis. Till now, we are using conventional physiotherapy to treat adhesive capsulitis, shortwave diathermy, transcutaneous electrical nerve stimulation, ultrasound therapy, and joint mobilization. But several studies have demonstrated long-term pain, shoulder stiffness, and disability following conservative treatment. So we need some new and much more effective treatment option for adhesive capsulitis. Literature reported that dry needling resolves the trigger points effectively in large number of conditions of myofascial dysfunction. Again in 2014, Sukumar S. et al. Confirmed that myofascial trigger point formation in muscles around the shoulder joint is one of the reasons for pain and reduction in range of motion in adhesive capsulitis. After that, Derek C. et al. In 2014 done a case study and concluded that trigger point dry needling can be used as adjunct treatment for a patient with adhesive capsulitis of the shoulder. Objective of the study. Our objective is to evaluate the effectiveness of myofascial trigger point dry needling in improving pain, range of motion, physical disability, and pressure pain threshold in trigger points among patients with adhesive capsulitis. Methodology. This is a single group pre-post experimental study, and this study was conducted in the Department of Physiotherapy in Kapoor Bone and Child Hospital and OPD of Saint Soldier College of Physiotherapy, Jalandhar, Punjab. And the inclusion criteria were unilateral adhesive capsulitis, patients aged between 40 to 65 years, and both genders were included, patients with taut palpable band or nodule within the muscle around shoulder joint, and patients with extreme tenderness of palpable band or nodule within the fiber. These patients were included in the study. We excluded those patients who are having anticoagulation or bleeding disorders, aspirin injection in the past 3 days, presence of the local or systemic infection, local skin allergy, acute muscle trauma around the shoulder joint, history of trauma in cervical spine in past 6 months, or extreme fear of needle. Procedure. We were taken 70 diagnosed adhesive capsulitis patients with the help of a purposive sampling method. After that, we got signed consent form from the patient, and then patients underwent pre-intervention assessment. In the pre-intervention assessment, we used VAS to measure the pain intensity, SPARTI to measure the shoulder pain and disability, universal goniometer to measure the shoulder range of motions, and we used pressure algometer to measure the trigger point pressure pain sensitivity. After the complete assessment, patient underwent treatment protocol. In the treatment protocol, we gave local myofascial dry needling for alternative 6 days along with conventional physiotherapy for continuous 12 days. After completion of the treatment procedure, patients were again go for the post-intervention assessment on the 12th treatment day, same as the pre-intervention assessment. In the dry needling procedure, first of all, sterile gloves were worn. Patient position was maintained appropriately according to the targeted muscle. Then the trigger points were palpated. Skin was cleaned with 90% diluted spirit. Then the needle was inserted in the trigger point and pistoning was done. Most of the occasions, local twitch response was elicited. Dry needle was left in the affected muscle for 10 minutes, then carefully removed it. We assessed following muscles. First one is the supraspinatus muscle. Second one is the infraspinatus muscle. Third one is the pectoralis major muscle. Fourth one is the teres minor muscle. Fifth one is the teres major muscle. And last, that is the sixth muscle, that is the deltoid muscle. In conventional physiotherapy treatment, we gave shortwave diathermy for 20 minutes and intensity was set according to the patient feedback. And pads were placed in contraplanar position. Next is the TENS, that is the transcutaneous electrical nerve stimulation. TENS was given for the 20 minutes with the frequency of 100 Hz and pulse duration of 0.05 millisecond. And intensity was increased till no observational contraction was seen. Next is the Maitland mobilization. We gave Maitland mobilization for glenohumeral joint, sternoclavicular joint and acromioclavicular joint. And we given following glides for the glenohumeral joint: antero-posterior glide, posterior-anterior glide, caudal glide, distraction or lateral glide. And for sternoclavicular joint and acromioclavicular joint, we gave antero-posterior glide, posterior-anterior glide, caudal glide, cephalid glide. We gave 3 sets of 10 repetitions and with the rest interval of 30 seconds between each set. Here is the result. First one is the demographic data. Our mean age of the subjects or patients were 54.4 years and 33 was the male and 37 was the females. 23 patients with right side affected and 42 patients with left side affected. So next is the result of our outcome measures. First one is the range of motion. You can see here in all the shoulder range of motions, our post-test readings are significantly improved than the pre-test reading. In pain intensity also, our post-test reading is significantly improved than the pre-test reading. And in disability, that is, we measured with the help of SPADI. Here also, our post-test readings showing significant improvement than the pre-test reading. In pressure pain sensitivity with the help of ergometer, pressure ergometer, all the 7 muscles showing significant improvement in the post-test readings as compared to the pre-test reading. So here we can conclude that myofascial trigger point dry needling techniques may improve the pain, range of motion, disability and pressure pain threshold of trigger points along with conventional physiotherapy management in short duration among patients with adhesive capsulitis. Limitation of the study. Our study is not having control group to compare the results. References of this study. Thanks a lot.